Good morning. This hearing will come to order. Mr. Secretary, thank you for being here with us today. We are gathered to receive the President's VA budget recommendation for fiscal year 2017, as well as the advanced appropriation recommendation for fiscal year 2018. As everybody knows, the budget request came out only yesterday, so admittedly, there's a lot for everybody in this room to digest. Mr. Secretary, I'm told you've come with charts today and to help us in that effort, and we thank you in advance for the visuals that you provided for us to be able to understand you a little more clearly. Let me briefly outline some areas that I'd like for you to cover for us in more detail this morning. First, I think there is general agreement among members of Congress that you, Mr. Secretary, and veteran organizations that greater reliance on outside care providers is absolutely essential to providing high-quality care for our veterans. The Choice Program got off to an uneven start, if you will, for the plethora of reasons, but the basic concept behind its inception still holds true today. Namely, veterans shouldn't be forced to travel or wait for a VA appointment if a community option is available to them. And if that option exists, it should not be, or it should be the veteran's choice, not the VA's choice as to whether or not they can exercise that option. The $10 billion Choice Program fund will more than likely be depleted within the next fiscal year. We've asked for and received a plan from VA to consolidate all of VA's outside care authorities into a new Veterans Choice Program going forward. We are aggressively working the legislation to make the program a reality, and I know that's something that's very important to you, Mr. Secretary. I'm also interested to know what the cost assumptions are in the budget for the new Choice Program for the next 2 fiscal years and how it can be paid for given the current fiscal constraints that exist here in Washington. And I'm also interested to see what impact greater reliance on outside providers is actually having on wait times. Simply adding more capacity within VA and opening up additional outside care options doesn't seem to have moved the needle yet much because, as the Secretary has told us, demand from existing and new users of the system has overwhelmed whatever new capacity is being created. This is an issue that the Commission on Care is evaluating, and we'll get the Commission's recommendations later this summer. But we need to make sure that what changes we're putting forward not only work, but are fiscally sustainable, but that they also lay out the groundwork for what the VA health delivery system will look like 20 years from now. Second, I think it goes without saying I've been pretty critical of VA touting its claims backlog reduction success because it really, I think, has ignored the experience of veterans whose waits have grown longer in other areas of the claims process. The growing appeals backlog is a glaring example, and I'm glad that the Secretary has put forward an idea for a large-scale structural reform instead of simply throwing more money at staffing over the next decade. I put forward a similar reform proposal in concept, so I'm interested in hearing more from the Secretary this morning about his ideas. And thirdly, the conversation we're having on the budget wouldn't be complete if we didn't discuss VA stewardship of taxpayer dollars over the last year. As my ranking member knows, we cannot have a hearing in this room without discussing Denver. It was a botched construction project. We know that it is going to be close to $1 billion over budget. The department has spent millions of dollars on art projects, relocation benefits, bonuses for failing employees. And last July, the agency threatened to shut down hospitals within weeks due to a budget shortfall that actually was kept internal in the preceding months, forcing Congress to give the department access to an additional $3 billion, all of which came out of choice. In classic fashion, I'm not aware of a single employee that's been held accountable for any of these unprecedented failures. and I will continue to fight to ensure that VA has the resources that it needs. But given some of the problems, this budget request is going to continue to receive every bit of scrutiny that I think the American taxpayers would expect us to give it. It's the very least we can do for our veterans and the taxpayers in our country. And finally, I'd be remiss if I didn't mention my frustration, and I'm sure many of the frustrations shared by my colleagues on this panel, of the recent string of Merit Service Protection Board decisions overturning disciplinary actions proposed by VA Deputy Secretary Sloan Gibson. We've got to have an honest conversation about what's happening within the civil service system. As the deputy noted in his statement last Friday after the most recent MSPB decision, and I quote, "It appears that the MSPB does not agree with the Congress or the VA's interpretation of the extent of my authority and has once again substituted its judgment for mine and demonstrated a willingness to second-guess the VA's application of legitimate high standards for accountability," end quote. I'll let the deputy's strong statement speak for itself, but needless to say, there's a massive problem here that permeates the entire conversation about the resources that VA has. Absent accountability, we are doomed to see repeated problems persist, no matter the budget that we provide to the VA, no matter how much the Secretary tries to make the changes at the VA. VA's mission of serving veterans is second to none in our government. Creating a higher standard for performance because of that mission is what the public expects of each of us. And I remain committed to working with you, Mr. Secretary, on how we can strengthen the system of accountability within the department and across the federal government system. It's imperative to everything you and we will attempt to accomplish for veterans. Mr. Secretary, before I turn it over to the ranking member, I'd like to take a moment to compliment you and your staff for the work that you all did in producing the final master plan for the West Los Angeles campus. I visited the campus a few weeks ago and saw the enormous potential for the restoration of the property and the mission of any future tenant of the property to its original purpose of serving the veterans. You've brought a lot of competing interests together who not long ago were extremely far apart. Considering the potential the West LA campus has in helping homeless veterans in the Los Angeles area to reintegrate into society, I salute you and the leadership that you've shown. And with that, I recognize the ranking member, Ms. Brown, for her opening remarks.
Thank you, Mr. Chairman, and thank you, Mr. Secretary. I want to thank you, and I also want to thank the President. During this President's tenure, discretionary spending has increased 86%. I think that deserves repeating. During President Barack Obama's tenure, discretionary spending has increased 86%. What this says is this president just doesn't talk the talk, he walks the walk, and as one veteran group says, he rolls the rolls. The president is doing his part to take care of veterans. And I believe that this budget provides us with a starting point to begin the process of making sure that veterans are getting the benefits and service we have promised them. I'm looking forward to discussing your proposal to establish an additional appropriation account focused on community care, especially in light of your repeated requests for budget flexibility. I want to be assured that this account will not take our focus away from providing the veterans with the resources it needs to provide health care to our veterans. In light of the shortfall VA faced last year and the uncertainty of reform efforts, I want to ask you, Mr. Secretary, the question I ask every year: does this budget give you what you need to accomplish your mission? Do you believe that there are areas that we need a special focus and may need additional dollars? I stand ready to do whatever I can to make sure that you have what you need. But while I will be in the front line of fighting for the dollars you need, I want to make it very clear. I expect you to spend every dollar we give you wisely for our veterans. I believe we must focus on our veterans. By focusing on our veterans, we will begin the process of rethinking how we ensure that we keep our promise to them in every year ahead. So let us know what you need, and we will work together on both sides of the aisle to make sure you have the tools and the dollars to accomplish your mission. And as I close, what happens when failure is not an option, and it is not? We are going to take care of our veterans, and with that, I yield back the balance of my time.
Thank you very much, Ms. Brown. I'd like to welcome our first panel to the table this morning. Accompanying the Honorable Robert McDonald, Secretary of Veterans Affairs this morning, is the Honorable Dr. David Shulkin, Undersecretary for Health, Mr. Danny Pummill, Acting Undersecretary for Benefits, Mr. Ronald Walters, Interim Undersecretary for Memorial Affairs, the Honorable LaVerne Counsel, Assistant Secretary for Information Technology and Chief Information Officer, and Mr. Ed Murray, Interim Secretary for Management and Interim Chief Financial Officer. I appreciate all of you being here today. I appreciate also your willingness to engage the committee members when we have questions and issues that come up outside of this room. Your openness with us is greatly appreciated. Mr. Secretary, you can proceed with your opening statement. Members, the Secretary has requested, and we've granted 15 minutes this morning for the Secretary's opening statement.
Thank you, Mr. Chairman. Chairman Miller, Ranking Member Brown, distinguished members of the committee, thank you for this opportunity to present the President's 2017 budget and 2018 advanced appropriation requests for the Department of Veterans Affairs. Mr. Chairman, 10 of our top 16 executives are new since I became Secretary, all with substantial business experience. Their fresh perspectives, combined with our more experienced government and healthcare executives, are catalyzing innovation, meaningful change, and opportunity. Our leadership team today is comfortable with and actually invites honest, sometimes tough discussions about transforming VA. With me here on the panel, everyone is new to position since I was sworn in as Secretary, with the exception of Mr. Walters. I have a written statement that I ask to be submitted for the record.
Without objection.
Thank you, sir. The President has proposed $182.3 billion for the Department in fiscal year 2017. We think it's a strong budget, another tangible sign of the President's devotion to veterans and their families. The President's proposal provides the funding needed to enhance services to veterans in the short term, to transform VA systems to better serve veterans over the long term, and to support and sustain progress that we've made toward ending the disability claims backlog and veterans homelessness. It supports VA's 4 agency priority goals: to improve the veterans' experience with VA, to improve VA's employee experience, to improve access to health care as experienced by the veteran, and to improve the dependency claims process. It also sustains our commitment to end veterans' homelessness, improves programs for veterans care in the community, streamlines and reforms the appeals process, advances medical and prosthetic research, strengthens veterans' benefits programs, and proposes increased budget flexibility. It supports our 5 MyVA transformational objectives to modernize VA's culture, processes, and capabilities, and to put the needs and the interests of veterans and their families at the center of everything we do. Improving the veteran experience is our first and primary strategic objective of the MyVA transformation. It is important that every contact between veterans and the VA will be predictable, consistent, easy, and outstanding. Second, making things better for veterans by improving the employee experience. We have no hope of improving the veteran experience without also training and improving the employee experience. Third, we want to improve internal support services and bring our IT infrastructure into the 21st century to enable employees and leaders to better serve veterans. Fourth, we want to establish a department-wide culture of continuous improvement that would be undergirded by Lean Six Sigma. And fifth, we want to expand strategic partnerships, extending the reach of services available to veterans and their families. And it will also continue to support our 12 MyVA breakthrough priorities that improve the delivery of timely care and benefits to veterans. My written submission addresses these breakthroughs in detail, but I'd like to quickly show you how the proposed budget supports these priorities for veterans, and I think we all agree on this. First, the 2017 budget proposal will provide $2.6 million for the MyVA program office to help integrate all the MyVA initiatives across the enterprise. It increases by 47% funding for our Veterans Experience Office so we can continue training field employees on advanced business skills, sharing best practices, and establishing high customer service standards. And it requests $171.3 million for IT systems that are instrumental to improving the veterans' experience. In support of our priority effort to increase access to the point that veterans' clinical needs are addressed the same day they call or visit primary care facilities at a VA medical center, the budget requests $65 billion for veterans' medical care. That's a 6.3% increase over 2016. And it proposes $66.4 billion in advanced appropriations for the VA medical care programs in 2018. That's a 2.2% increase above the 2017 level. The proposed budget provides an expected 35,000 veterans access to hepatitis C treatment. It funds telehealth access, and it enhances health programs for women veterans. And $7.8 million is provided for mental health, which continues to support successful mental health care-related prevention programs. We're committed to making sure that when veterans call for new mental health appointments, they receive suicide risk assessments and immediate care if needed. Veterans already engaged in mental health care who need urgent attention will speak to a provider the very same day. The 2017 budget includes $12.2 billion for care in the community and includes a new medical community care budget account consistent with the VA Budget and Choice Improvement Act. Proposed IT investments will fund veterans' enterprise-wide integrated services platform with best-in-class service and satisfaction measures and expand veterans' access to self-service tools and benefits information. Veterans should have access to VA systems and know where to get accurate answers 24 hours a day, 7 days a week. The 2017 request supports this priority by funding veteran contact centers in the field and Veterans Crisis Line modernization. To expand veterans' access to the benefits they've earned and deserve, the proposed budget supports increased contracted disability exams at all regional offices. And it proposes a simplified, streamlined, and fair appeals process so most veterans could have a final appeals decision within 1 year of filing. With your support, 5 years from now, veterans could have a process that resolves 90% of their appeals within 1 year. To that end, the proposed budget requests a 42% increase in Board of Veterans Appeals funding to $156 million and a 35% increase in board staffing to more rapidly address the growing inventory of more than 440,000 pending appeals. Under this plan, by 2022, we could reduce appeals FTEs to a sustainment level, sufficient to process all simplified appeals within 1 year. The simplified process makes sense for veterans, and it's an excellent return on investment for taxpayers, too. The proposed sustainment level is 1,135 FTEs fewer than the fiscal year 2016 budget requires, and 4,070 fewer department-wide than necessary to address the appeals workload with FTE resources alone. The fiscal year 2017 proposal continues our progress toward an effective end to veterans' homelessness by focusing on proven prevention and treatment services and veteran homelessness programs like SSVF, HUD-VASH, grant per diem, home loans, and foreclosure prevention. It provides services to about 65,000 homeless veterans or those at risk, prevents an estimated 36,000 veterans and their family members from becoming homeless, and provides case management support for over 63,000 who receive HUD-VASH vouchers. It's no coincidence that the very best customer service organizations are almost always among the best places to work. So the proposal provides for the training that supports our MyVA transformation. In the same vein, the proposed budget will help us significantly improve critical staffing levels that balance access and clinical productivity and reduce time to fill standards so we can move quickly to hire the people the veterans need to serve them. With the funding requested, we can continue transforming our IT infrastructure to create a world-class IT organization supporting veterans and our business partners, and to do the work necessary to build an enterprise-wide integrated medical surgical supply chain that leverages VA's scale to increase responsiveness and reduce operating costs. We'll redirected to priority veteran programs over $150 million in cost avoidance savings from transforming our supply chain. The proposal includes $78.7 billion in discretionary funding. That's $3.6 billion above the 2016 enacted level, largely for health care. It includes $103.6 billion in mandatory funding for veterans benefits programs. For the second time, the budget requests VBA advanced appropriations. $103.9 billion is requested to fund compensation and pensions, readjustment benefits, and veterans insurance and indemnities for 2018. And the 2017 proposal fully funds construction. These are investments in the future, and they're critical to providing both quality care and timely benefits in first-rate facilities that are safe for veterans and VA employees. We'll continue to work closely with the U.S. Army Corps of Engineers, our construction agent, to execute 2 projects over $100 million. So with this budget, there's a lot we can change on our own, and we're doing that now. But many important priorities that will make meaningful differences for veterans require Congress to act on behalf of veterans. You'll find more than 100 legislative proposals in the budget. Over 40 of them are new for this year, some absolutely critical to even maintain our current ability to purchase non-VA care. Here are just a few of the most important ones. First, in this session of Congress, we can make significant improvements to set the foundation for top-to-bottom transformation and streamlining of VA's care in the community programs based on proposals in VA's landmark roadmap plan set out in our October 30th report to make these programs more rational and to better serve veterans. Second, the budget proposes a general transfer authority that allows me some measured flexibility to transfer up to 2% of discretionary funding across accounts, excluding medical care, to address emerging needs and overcome artificial funding restrictions on providing veterans cares and benefits. Third, it's critical that VA is competitive with the private sector for top healthcare talent. So we're proposing flexibility on the maximum 80-hour pay period requirement for certain medical professionals. The private sector has this flexibility, and it makes sense in running a hospital. This flexibility can both improve hospital operations and help attract the best hospital staff who use and prefer more flexible schedules. Along the same lines, we're proposing critical compensation reforms for network and hospital directors. Other adjustments to VHA personnel authorities we're putting forward also reflect common sense and good practice and best practices from the private sector. Fourth, we need your help to change VA's purchase care authorities, provider agreements, and individual authorizations so veterans have access to clinically indicated and timely care. Failing to address this requirement in the weeks and months ahead impacts potentially thousands of veterans receiving care from local non-VA doctors, hospitals, nursing homes, and state veterans homes. Fifth, we're looking for congressional authorization of 18 leases submitted in VA's 2015 and 16 budget requests, as well as authorization of 8 major construction projects included in VA's 2016 request. And we need your support for the 6 additional replacement major medical facility leases, 2 major construction projects, and 4 cemetery projects in the 2017 budget. 6, Passing special legislation for VA's West Los Angeles campus will get positive results for veterans in that community, especially veterans most in need after years of debate and court action, as the chairman said. 7, finally, as I implied, we have to change the current appeals process. Last year, the board was still adjudicating an appeal that originated 25 years ago. The appeal had previously been decided by VA more than 27 times. Conceived over 80 years ago, it's unlike any other standard appeals process across the federal and judicial systems. It's complex, it's confusing, and it's ineffective. Under current law, without significant change in resourcing, pending appeals are projected to soar by nearly 400% to almost 2.2 million by 2027. Together, we can do this, and we're open to ideas from the committee and veteran service organizations to make it work for veterans. If we're serious about changing VA and better serving veterans and their families, we can't keep kicking the can down the road. This Congress, with today's VA leadership team, can make these changes and more for veterans. Then we can look back on this year as the year that we turn the corner. But we have to be courageous and we have to work together to make that so. This is my second budget cycle, and I appreciate the support that you've all shown to veterans, the department, and our My VA transformations. On behalf of veterans and the VA employees serving them every single day, thank you for this opportunity. Mr. Chairman, I look forward to your questions.
Thank you very much, Mr. Secretary. According to the slide deck that VA provided yesterday, you anticipate spending $1.7 billion in fiscal year on the choice program. We discussed this a little bit yesterday. How much money is left in the choice program today, or close?
As we talked yesterday, Mr. Chairman, we expect the choice program funding to run out before the budget year 2018. We'll get you the exact number here. Ed?
If you would, turn the mic on, thanks.
Oh, thank you. So our estimate for the choice program for Section 801 for 2016 is $2.7 billion, and under 802, where we provide care in the community, it's $1.7 billion. In 2017, we estimate spending $969 million for Section 801 and a $4.8 billion in Section 802, and that rounds out the 10 and the 15 together, and we can provide you the details on that.
And you anticipate it exhausting the funds when?
At the end of 2017.
So could you explain, and again, we discussed this a little yesterday, but can you explain the discrepancy that VA states that the choice utilization has markedly increased in fiscal year 2016, and the low dollar figure presented in the budget materials? In other words, why are choice expenditures estimated to be more than 3 times higher for 2017?
Go ahead, Dr. Shulkin.
Mr. Chairman, as you know, and I think that you characterized this correctly, the choice program got off to a rocky start. We have been working very hard to get veterans access to care through choice, and we've seen the results of that. We're seeing increased authorizations in significant numbers, and that's leading us to the projections that we'll be spending much more money using choice funds to serve veterans.
The advanced appropriation requested for fiscal year 2018 is nearly $2.5 billion short of the 2017 request, and almost $1 billion short of what was actually paid in fiscal year 2015. So how does the VA envision addressing the inevitable budgetary shortfall that's out there?
As we talked yesterday, Mr. Chairman, I think what we're going to need to do is come back with the work that we do in the consolidation of care in the community and come back with what we think the number will be for 2018. really the top priority for us is getting into that consolidated program. As you know, in the consolidation plan that we put forward, there were a couple of options that we laid out for the committee. One was dealing with the emergency room. One was also dealing with what we think could be incremental demand from more veterans using the system. What we've seen already, and you reflected this in your remarks, is veterans already have a choice. 81% of veterans have some form of Medicare, Medicaid, private health insurance. And as we continue to improve the care from the VA and the care in the community, more veterans are going to choose to use our system because our co-pays are zero. And right now, our estimate is the average veteran uses VA for only 34% of their care. If that increases 1 percentage point, it's about a $1.5 billion increase. So we need to get a better handle on this as we work together on the consolidation of care in the community.
I think that the committee was pretty clear, and the Congress was, with the Choice Fund program was intended to supplement VA's community care budget. However, I saw in the budget where it's assuming $7.2 billion for community care funds, which are distinct, should be distinct from choice funds. And that's less than what you had budgeted and spent in each of fiscal years 13, 14, and 15. So my question is, do you think that VA is compliant with the intent of the Congress when the law was passed?
I certainly think so. Ed, do you see any?
I did want to mention that for the, we'll get a second choice in the we'll get a chance in the next year this time to revisit the appropriation for 18. So I just wanted to put that in there. Once the consolidation and the care and the community recommendations are made, we'll get another opportunity to review our numbers for FY18.
Yeah, again, Mr. Chairman, I think the most important thing is we got to get the consolidation of care in the community law passed and decide what's going to be part of that, if the change in the emergency room structure is going to be part of that, and then we got to decide what the demand's going to be, and we'll work with you on future budget numbers that will go with that.
Okay, we'd like to have a little extra time to talk to you about what our assumptions are and why we think there may be an issue where there's a deviation, and maybe we can all get back on the right track. I have one more real quick question. The major and minor construction requests are substantially lower than what you requested last year, and I understand that's because we're waiting for the study for the Joint Commission to come out later this summer, and I think that is the appropriate thing to do. The 800-pound gorilla, if you will, is going to be if they recommend closing underutilized facilities. Are you prepared, Mr. Secretary, to full-throatedly support that? Obviously, you will have to ask for our help as well.
Mr. Chairman, as you know, for the last 2 years, I've had in my written budget proposal productivity improvements for the department, and I have specifically called out 10 million square feet of unused space that results in a charge to the taxpayer of $25 million a year. And we have a number of these facilities where we need the courage of the members of Congress to help us close them so that we can turn those savings into productive use of funds for veterans.
Thank you very much. And Ms. Brown just said she has a facility she'd like to put up on the chopping block, so I will yield to her.
Mr. Chairman,
Whose district is it in?
Mr. Chairman, all I said was just as long as it's not in my district, and I bet every single member feels that way. We support that, and please don't charge that against me. I have a couple of quick concerns. That was a wonderful conference you all had last week on the suicide prevention, and I want to thank you for that. But one of the things that came out, 22 a day, which is totally unacceptable, but only 3 of them are in the VA system. What are we doing to get those veterans into the system, and have you included that in your budget?
Yes, ma'am. Actually, what we said was 22 a day and 17 not connected to the VA system. So 5, as you pointed out, if we can get people connected to the VA system, we know how to treat them and we know how to prevent suicide. So outreach, as you described, becomes a very big issue, and I'll let David talk about what we're doing.
Well, First of all, thank you for personally being there, and to the chairman and so many members that came, because we know this is very important to you and very important to us. This conference, as you know, was focused on this exact issue. How do we get people that are isolated and not seeking help back in? And what we essentially believe is we need the help of the community. VA can't do this alone. So we had at this conference community groups, the Department of Defense, many other organizations that we believe we need to work closer with. And the essence of this is that what we learned is we need to do a better job in the transition time when a military member leaves service and then gets into VA. We need to make that a much more thorough process to get people help. We also have learned that we can do better in predictive tools, using big data analysis and using the research that's actually done at VA to predict who's at greater risk. So we're working on that, and we're coming up with a plan 30 days from the conference with very specific actionable steps that we're going to put into place.
Let me add that women, one of the fastest growing groups of the military, are also the strongest as far as suicide. And I hope we're targeting our model toward making sure that they get the help that they need.
We are. In fact, since the year 2000, the number of women veterans seeking VA health care has skyrocketed from 160,000 to 447,000. So we are putting in place all kinds of programs which we can talk about, whether it's having designated women's health providers at all of our facilities, or whether it's having 100% of our medical centers with women's advocates, having women's clinics, having obstetricians, gynecologists. We really have to transform the entire VA system to serve our female veterans, and that's a big effort for us.
And one of the things, the elderly veteran, the Vietnam veteran, is one of the, most people think it's the younger veteran, but it's really the older veterans that is committing their suicide. So I'm hoping as we do our modeling that we'll be looking at that. I have one other quick question I want to ask. We had a hearing last week about hepatitis and what we're doing as far as the pharmaceuticals. And I know at one time that we wanted the VA to work with the Department of Defense on the formulary so we could keep that cost down for all of people with service. Can you give me an update on that? Because the cost of the pharmaceuticals is unacceptable, particularly since we put the money up front.
There are, our plan, the plan that you've got here, is to eliminate hepatitis C amongst veterans over about a 5-year period. We are in negotiations. There are alternative drug treatments now, and we are in negotiations to get those costs down as low as we possibly can. And any savings we turn up, we will obviously plow back into the budget to better care for veterans.
I would just add, with the Department of Defense, we are coordinated purchasing our drugs together, and we're using the federal government size and scale to be able to get the best prices for taxpayers.
And in closing, the VA and HUD needs to work closer together in talking to lots of the homeless facilities. Part of the problem is that definition of the vouch. We don't want the veteran to be under the bridge before we can intervene and provide care. And so we need to work together with those interagencies to make sure that we are doing the best thing to prevent homelessness. Thank you, Mr. Chairman. I yield back the balance of my time.
Yes, ma'am. Mr. Lamborn, you're recognized.
Thank you, Mr. Chairman. Mr. Secretary, I am very upset about the IG report, this report that came out on the clinic in Colorado Springs last Thursday. And I know you're here to talk about the $182 billion budget, but I've got to ask you about my district, as referred to in this report. According to your testimony, looking at all appointments nationwide in fiscal year 15, quote, more than 97% of 56.7 million appointments were completed within 30 days of the clinically indicated or veteran's preferred date. But according to this report, which looked at appointments at the clinic in my district, also in fiscal year 15, only 36% of veterans were able to get an appointment within 30 days. There's 100,000 veterans in my district. 36% is a lot worse than 97%. So either the 97% number you give us is unreliable, or veterans in my district are getting extra poor treatment. Which is it?
Well, as you know, Congressman, and I know Deputy Sloan Gibson talked to you about this last Friday, this report from the IG is about a year old, almost a year old, and as a result, we've taken many steps since this report was issued. The clinic manager has been replaced, 16 additional schedulers have been hired, and we've consolidated training and supervision and accountability. The bottom line is that since March of 2015, Colorado Springs has been aggressively implementing the choice program. Wait times are coming down. We obviously have more work to do, but this report is about a year old.
Well, as for accountability, will anyone in the future be fired, or can we say that anyone was fired? Heads need to roll when something like this happens.
Well, first of all, when I read the report, what came out of the report to me was we did not do a good job training people. Not that there was malfeasance. I know in your letter you said deliberately falsified appointment records to prevent these veterans from receiving care, intentionally delay the medical care of our nation's veterans. I read the report. I didn't see that. I mean, it was in your letter, but I didn't see it in the report. I think if you read the report closely, the IG did not make any kind of accusations about people falsifying records or doing anything like that.
Well, I did review the report closely, and we had that conversation, Secretary Gibson and me. But here's what the IG report says. It says, scheduling staff used incorrect dates that made it appear the appointment wait time was less than 30 days. Now, maybe it wasn't done maliciously, but
well, so your letter again says intentionally delay the medical care, deliberately falsified appointment records. That is not what's in the IG report.
Okay, when it says scheduling, the IG says scheduling
The people
staff,
were poorly trained. They were poorly trained, and we admit that. And as I said, the clinic manager's been replaced. We've hired 16 additional schedulers. We've also consolidated training and supervision. This is a training issue, and we're after it, and that's why the care is improved. But we need to go further.
whether it was done maliciously or not, I think the records were falsified, and I think that that's a correct term to use. And I think someone needs to be fired for this. Was the person that was let go, was that person actually fired, or were they just allowed to be transferred or allowed to retire?
Maybe, Mr. Chairman, maybe we should make the IG report a matter of the record so that the American people can read this, because the investigation makes no such accusations.
It's already publicly available now on the IG's website,
Yes, sir.
Mr. Secretary.
Let me ask you about the Veterans Choice Act. We talked with someone out of this same part of Colorado who said she did not agree with the choice program, and quote, the VA will always take better care of veterans than the community, and that the community is not capable of taking care of our veterans. Mr. Secretary, there is widespread, I perceive widespread defiance and resistance to the Choice Act. Is that something that we're going to still have to face in the future, or is there going to be a better attitude on the part of VA bureaucracy?
I don't perceive that, but we're going through a process right now called Leaders Developing Leaders. It's a program that we put together to train all the leaders in the VA. We've trained over 12,000 leaders so far. Part of that training is basically sharing with everyone the vision that the optimal network of the future includes inside VA care and care in the community. So if you find someone who you think doesn't understand that, please provide us the name, and we will certainly share our vision with them. But I think everybody gets it.
Mr. Takano, you're recognized.
Mr. Secretary, you have shared with members of this committee in a variety of different formats your vision for moving the VA toward your vision of care in the community. I want to, I support what you're doing, and hopefully we can all work together to make sure that we enable you to consolidate all of the various care in the community programs. But I have some questions about some other parts of your budget. Maybe you and your cohorts can help explain. The fiscal year 2017 budget requests $567 million for substance abuse, an increase of only $9 million from fiscal year 2016, and a decrease of $57 million for your estimate of last year's. Can you explain this change in estimate with the ever-increasing opioid addiction crisis facing our states?
Our VA has prioritized the issue of substance abuse. There's no question about it that this is a growing problem. We have put together some new efforts to be able to address this. We think that the budget requests that we've submitted will allow us to be able to focus on this and increase our efforts to be able to make an impact on this. We've just joined a White House effort to be able to address heroin abuse in the rural areas that's being led by the Secretary of Agriculture that VA's participating in. We are working with other federal colleagues in other agencies to be able to help address this, but we are very interested in doing more, and if there are other ways that you think that we should be stepping up or other ways to do it, we will use whatever resources we have to be able to address this.
I think I would say, too, that opioid use across VA, and again, it's just a general average, is down, and the use of alternative treatments we're finding more and more successful, whether it's equine therapy, acupuncture, yoga. We will try anything in an evidence-based way that works, and we're seeing great success with these alternative programs.
So you are noting a decrease in opioid abuse, but what about overall substance abuse?
You know, as the Secretary said, we have shown that we actually have 16,000 fewer veterans on prescribed opioids. So we are making progress there. We still have more work to do. The illicit drugs being used in heroin are a national epidemic, and unfortunately we're seeing that also increase in the veteran population. So we need to be doing more, and we are engaged in looking for ways to make our programs more effective and to do better outreach. VA has huge programs in substance abuse, as you identified.
Well, how are you sharing your best practices throughout the VA?
We are doing research that we publish on this, and so that's available throughout, you know, once we publish it, it's available to the scientific community. We're holding conferences on this. We work with SAMHSA, the other federal agencies that are involved in substance abuse on a regular basis. We're working with the CDC on efforts in substance abuse as well. But, you know, this is such a national epidemic and such a crisis for veterans that we are very open to new ways, new ideas to be able to effectively treat veterans.
In some of the work that we've done, I've actually spoken at groups, associations of doctors worried about reducing pain medication. I did one in West Virginia. I know David has done some. I've spoken to the American Medical Association. I've spoken to the Institute of Medicine. We've got to play a leading role in using our evidence-based alternative therapies as ways to get people off of opioids and also to deal with the substance abuse issue that's national.
Well, I note that you're increasing your mental health budget significantly, and perhaps there's some spillover there. But I want to quickly, before my time runs out, get a question about you know, the shortage of healthcare providers around the country, and whether you believe your budget includes the resources that are necessary to maintain and expand the VA graduate medical education in order to recruit and retain healthcare professionals.
We do, but there's a critical piece of legislation that we're asking for help for, and that would be the 80-hour work week, which will allow us to hire people into emergency rooms and to work flexible schedules. Also, we're asking for Title 38 categorization for our medical center directors. Our medical center directors who are not Title 38 are paid roughly half of what's made in the private sector. As a result, we have a number of vacancies that we're trying to fill. So to be competitive, we need those pieces of legislation passed.
But as far as medical school education, though,
Medical school education, I've been to
graduate medical school.
over 24 medical schools recruiting. I find that our problem recruiting is not that difficult, and that we're outreach. Most of the medical schools will tell you they can increase their throughput, but that they need the residencies, and I know we're in conversation with Dr. Rowe right now and the Doctors Caucus at getting more resident positions that we can put against primary care, mental health, and into rural areas, because that's where the need is great in the country.
Okay, thank you.
Thank you.
Mr. Bilirakis, you're recognized.
Thank you, Mr. Chairman. I appreciate it. Welcome, Mr. Secretary. Thank you for your testimony. Also, thank you for taking my call the other day with regard to a wounded warrior that needed assistance, and thanks for following up. I really appreciate it so very much. Mr. Secretary, again, the President's budget includes a request of $7.8 billion for mental health programs and efforts. It's encouraging to hear that more and more veterans are utilizing the VA or DOD to treat their invisible wounds, which has increased yearly again. However, the heartbreaking statistic is the 18 to 22 veterans taking their lives daily delves deeper into the discussion regarding the effectiveness of our current programs. Does the VA track data regarding how many veterans that started VA programs to treat their mental health issues finish the treatment programs, and are the mechanisms in place to survey the veterans' opinions on the successes and areas for improvement? Because one size does not fit all, and I understand that veterans start these programs and sometimes do not finish them and have nowhere to turn. That's why it's very important that we get these alternative treatments into the VA on a regular basis. I want to ask you that question too. How many treatments, I know you brought it up, but how many complementary alternative treatments programs, such as equine therapy, service dog therapy, yoga, what have you, do our veterans have access to these programs on a regular basis? And in my opinion, we need to expand these programs, and I filed legislation to do so. Of course, they must be evidence-based, but I want to ask that question. If you have again, these programs within the VA, are we tracking them to see how many veterans finish those programs and how effective they are?
Yes, and yes, we need to track these veterans very closely, because the #1 cause of missed appointments are people with mental health care appointments, and so we need to track them very closely. I'm pleased to tell you that we had a situation in Vermont, White River Junction, where we had a veteran not show up for an appointment, and one of our nurses, seeing that veteran didn't show up, rather than following the rules, and we're talking about changing our organization from a rule-based organization, a principle-based organization, she contacted the VA police. The VA police contacted the local police. They went around the house. They discovered there weren't footsteps in the snow. Neighbors hadn't seen this individual. They actually broke into the house and found this veteran lying on the floor, wedged between two pieces of furniture. The person would have died if this nurse hadn't been tracking that appointment for that veteran. We have celebrated that nurse's behavior. We've celebrated her principle-based way of operating, and it was my honor to celebrate both of them recently for what they did. And we're using that as an example to all of our employees as to how we should think about the veterans we serve. David?
I would just say, Congressman, you've identified a very, very tough issue in the treatment of mental health disorders. Our no-show rate with mental health appointments is 21%. So you're absolutely correct.
That's unacceptable.
Yep, very, very difficult. This, of course, is the same thing that you find outside the VA system. The VA is absolutely trying to target this issue of noncompliance. We're doing more than I've seen anywhere else. We use peer counselors to be able to help with this. We have our vet centers, 300 of them across the country, as another source of a place to get information and to bring back into the system. But every one of our suicides, we do what's called a root cause analysis to look specifically at this issue. What could we have done better to bring people in? I was reviewing a root cause analysis today where we actually walk the people over to the schedulers to make sure that they schedule. We can't force them, unfortunately, to show up, and that's where our noncompliance rate is. So
Are there mechanisms in place to survey, to get the opinion of the veteran with regard to these programs, if they're effective?
this is what I would call research, where we are looking at different ways to improve compliance. We have 2 facilities right now that are surveying veterans using functional scores every time they visit to look at this issue. We're trying to learn what works so we can spread that.
Okay, so we have about a $7.8 billion budget.
Yes.
Okay, how much is going toward these alternative and complementary treatments?
Yeah, that would be outside. The alternative complementary treatments
within
are in
the
our
communities.
patient-centered, a different medical services budget. And again, VA has one of the largest programs of these integrative medicine or alternative medicine type facilities that we are continuing to learn what works and spread it throughout the system. We have more to do because not every facility has access to this. The type of workers that are experienced and trained in this are somewhat limited, but we are continuing each year to bring more of these services to our facilities.
Well, thank you very much, and I guess my time has expired. Thank you, Mr. Chairman, appreciate it.
Ms. Titus, you're recognized.
Thank you, Mr. Chairman. Thank you, Mr. Secretary. I have a couple of issues. I'll just throw them all out there and then ask you if you would please address them. First and foremost, the appeals process. You've heard me say so many times that I see this as a new tsunami that we need to try to address before it continues to get worse, and your figures are pretty compelling in that argument, 440,000 currently, taking 25 years. And I appreciate very much that you've given us a chart to how to simplify this process and that you've asked for additional resources. I would ask you, though, of those 300 additional FTE, I think it's called non-related workload, how many of them will actually be, or workforce, how many of them will actually be working on appeals? And also, when can we expect to get some specifics about the legislative changes that we need to make? We talked, and I appreciated that, and I've also reached out to the VSOs to say, give us your recommendations, because we need to get busy on the legislative side, and so we need some specifics on that. A second thing I would ask you about is the medical research. You got in the budget $663 million, which is an increase of about $33 million for medical research. And we've talked about this before, the need to do research on medical marijuana as an option. And I would ask you if any of that is scheduled to go for medical marijuana research, and if not, if we could work together to try to make that happen. And then third, and this is something that's happening in my district, I've brought it up before, but veterans nursing homes. I realize that the VA provides grant money to the states, and then the states through Medicare or Medicaid are then responsible for them. But I wish we could look for some way for the VA to have a little more oversight of those nursing homes, because some of them just really aren't operating up to standard, and the VA doesn't seem to go back and check on them very often. And I wonder if there's somewhere that could go in the budget. So those would just be my 3 areas of interest right now.
We'll take them one at a time. We'll start with appeals. Let me get some facts out on the table. So about 11 to 12% of veterans appeal their decision. Of that 11 to 12%, if you took the percentage of total, about 2% of veterans, 2 to 3%, are responsible for about 45% of the appeals. So what's happening is you have people appealing and appealing and appealing. Some have appealed for 80 times. Some have appealed for multiple years. We have had conversations with the veteran service organizations about what the change in law would look like, and we shared some thoughts yesterday with the ranking member and the chairman, and this is going to take a team effort, and so we're going to have to all get together and decide what the change in law is. We put a straw man in our budget proposal, but again, it's just a straw man for people to react to. And we will be working that collaboratively over the time. You asked how many people, Danny, how many people?
Congresswoman, for FY16, you gave us 730 people to add to our non-rating workload, and we put a large number of those into the appeal process on the VBA side. We have an additional 300. We actually hired them in 15, so we get them hired, trained up, so they'd be ready to go in 16. The next batch, the 300, we're going to put 100 into appeals. On the other side, and the Board of Veterans Appeals, their budget was increased by $46 million, and they're going to increase the number of judges and appellate people they have on their side to do that. So the combination with the increased budget at the VBA, the increased people that they're going to put on the job, the extra people that we're going to put on the VBA side, and if we can get some kind of reform, all that combined together, we think we can attack this problem and solve it.
Medical marijuana, I'll let David handle.
Yeah, Congresswoman, I am not aware that VA is doing any research right now on the medical impact of medical marijuana. Be glad to work with you on that issue. It's an important issue right now. We are not doing that. On the state nursing homes, VA, as you know, funds this through a matching program, but does not have the responsibility for quality oversight. All that we have right now is an annual inspection. Again, if there are specific concerns on that and you think that we should have a more active role in that, be glad to work with you on that.
Well, thank you. I appreciate that. I would like to look at that. And I also think that as more and more states legalize medical marijuana and veterans don't have that as an option, we need to look at that. And if you think we need more testing, which I agree with, then we should be doing that testing. And as for the appeals, we've got to get a legislative solution. And you can't just keep putting more people and more money. That's not going to solve it. So Dr. Abraham and I on that subcommittee for disability, I appreciate working with him, and please keep us in the loop as you come with some of these suggestions, I would say.
Yes, ma'am, and as you know, in my testimony, I actually talked about reducing the number of employees once we get this resolved with the law. Thank you.
Thank you. Thank you, Mr. Chairman.
Dr. Rowe, if you would yield just for a moment, Ms. Brown has a quick question.
Yeah, I have a question to the Secretary. My understanding, under the medical marijuana, we in Congress prohibit you all from doing anything. Is that correct?
We are not allowed to prescribe medical marijuana. We can have, our doctors are permitted to have discussions with their patients in states where medical marijuana is legal about the use of medical marijuana, but we cannot prescribe it as an agency of the federal government.
Thank you. I yield back.
Dr. Rowe.
Yes, and just for the record, on the medical marijuana issue, it's a sore spot with me. It ought to be studied like any other chemical. It has not been. And, you know, I feel good is not science. That's how you feel. And so I think we need to study it like any other chemical. I totally agree that it's not science-based. And so there is no science right now. I just reviewed this whole business with medical marijuana. There is no science about the medical marijuana benefits. So anyway, that's a different issue. I want to bring up just a couple things very quickly. A study was published just about 3 or 4 days ago that showed that death rates and readmissions at VA hospitals for heart attacks, heart failure, and pneumonia were similar, in the JAMA, were similar, almost identical to the private sector. So I think it speaks that the quality of care the veterans get once they're in is comparable to the outside. And I think that's a shout out, and I think that's science right there. I think what we need to do is make it easier, obviously, and you're trying to, I think, Mr. Secretary, for veterans to access the care there. So I think once they're in the system, the care is comparable. At least this study at JAMA definitely showed that. Just 2 or 3 things I'd like to talk about. One is homelessness. That's something, to me, I think it's been an emphasis of mine since I've been here. I want to have you comment a little bit on that. I think you mentioned about principal care, and I would just think that's putting the patient first. And I think that's what this nurse did. That's what nurses do. It's what doctors have done forever. And I think the system has prevented that sometimes from happening. And I think it's a shout out to this nurse who just didn't care what the system was. She cared about her patient. And I think that's what we need to have. That attitude needs to come from the top down, and I think it's beginning to. So first start with homelessness. We discussed a disability backlog. Obviously, it's better than when I came 7 years ago. There were 1 million claims when I came here and first sat on this committee. So, and the last thing I want to talk about is that I think is critical for the long-term future of the VA's implementation of the VA residency programs, and make sure we do that right. So I'll stop.
I'll start with homelessness, and David can deal with the medical issues. On homelessness, we're making progress. I mean, homelessness, veteran homelessness is down 36% since 2010. Unsheltered veteran homelessness is down 50%. That's all good, but we're getting to the point now where we literally know the veterans who are homeless by name. We literally know them by name. And as the chairman said, and I appreciated his comment, the work that we've done in Los Angeles is largely about homelessness because Los Angeles, compared to other cities around the country, is the place where there's virtually twice as many as you would find elsewhere. I mean, some of the cities who have claimed an end to homelessness have housed the number of people over a year that Los Angeles has to house in a month. Wow. I mean, it's that big of a problem. And we were prohibited on our campus from doing extended use leasing, which we do. We work with partners, private sector partners who build residences for us. We have one in Menlo Park, which is just not far from Los Angeles. So as soon as we get that legislation, we're going to be working very, very quickly. Our master plan has a commitment for 1,200 beds in Los Angeles. After Los Angeles, it's San Diego. And what we're finding is the areas we need to work, and I'll be quick about this. Number one is we need landlords to rent for the HUD-VASH voucher amount, or we need to change the HUD-VASH voucher amount. In Los Angeles, we've changed the amount twice. Number two, we need developers willing to build these buildings for us, willing to get a rate of return on housing these homeless veterans. Number three, having the caseworkers to do the wraparound care. We hired about 300 for Los Angeles. So we're making progress, but there's still a lot of work that needs to be done.
What you pointed out is what we found is the housing stock. And
yes.
If you have a chance to visit, we'll take you by some developers who have accepted what the HUD-VASH voucher pays and provide that housing stock.
Love to do that.
Dr. Rowe, I would just say I'm very impressed that you're able to keep up with the medical literature. The study that you referred to in the Journal of the Medical Association was just released yesterday. It actually showed that VA has statistically better mortality for acute myocardial infarction and for congestive heart failure than the private sector, which I think has surprised a lot of people, but it doesn't surprise us because consistently VA has had either equal or better performance when it comes to mortality compared to the private sector. So thank you.
I yield back.
Another interesting statistic in LA is they have a 1%, I think the number was, vacancy rate. I mean, it's astronomical. There just isn't anything there to be rented out, and that's why this master plan, I think, is so critical. Mr. O'Rourke, you're recognized.
Thank you, Mr. Chairman, and Mr. Secretary, I'd like to thank you and your team for the presentation today and all of the work that you have contributed to improving access to care for our veterans and all the other responsibilities within your purview. I want to, in addition, commend you for the focus on mental health access and treating veteran suicide like the crisis that it is, and meeting that crisis with a sense of urgency. So the $7.8 billion to improve mental health access is certainly welcomed. I would ask that in addition to your comments, that it be a standalone priority within the VA. Much the way reducing veterans' homelessness is a standalone priority, I think veteran suicide is just that serious, and we still are in a crisis. And I think articulating that from the very top, that this is, in addition to overall access to better health care, physical and mental, reducing veteran suicide is a priority. I think the more we say that, the more we act on that, the more we follow through, the better outcomes, the fewer deaths. This is wholly preventable, and I just, again, want to thank you.
Congressman O'Rourke made a suggestion to us when we met and went through our 12 priorities for the year to call out suicide prevention. We had it there, but we didn't have it called out as explicitly, and we've changed that. So we thought it was a good suggestion. We do listen, and we do look for your comments, so we do try to improve.
Thank you. I really appreciate that. On that same note, we know that access, I think we know, I certainly feel this way, that access to mental health is connected to successful suicide prevention and treatment for those who have suicidal ideation. As you know, in El Paso, but throughout the country, we have critically underserved areas when it comes to mental health. To use El Paso as an example, We have the same mental health staffing today that we did in September of 2014, when we really became aware of how critical the crisis was in El Paso. And I know that Dr. Shulkin, Gail Graham, the interim director, Brian Olden, head of mental health in El Paso, are all doing amazing work, and yet it's not working. I want to know what we are going to do to elevate it beyond where you are today, to recruit those providers to underserved communities like El Paso, because I know that those providers will prevent suicides. They will save lives if we can get them in our community. So what additional flexibility do you need to pay them more, to forgive more of their medical school debt, bonuses to retain them in place if they're performing according to the standards that we have set for them, and what can we do to implement the very exciting proposal that Dr. Shulkin presented in October, which would have us leverage partnerships for what I would call non-VA core competencies and elevate those conditions like PTSD and traumatic brain injury that are uniquely connected to combat and service. So don't hire the podiatrist, no offense to podiatrists and people with issues, but that could be seen in the community. I'm sorry, Brad, but that psychiatrist, we are going to focus almost monomaniacally on getting that psychiatrist into our medical centers, to the exclusion of some other types of providers whose capacity is already represented in the community.
Right. You know, I think as we have worked together on our relationship with the local medical school in El Paso, to me, the top priority has got to be getting more residencies in there for mental health. There's just no question about that. And David and I have talked that as we put these residencies out, mental health, primary care have got to be some of our top priorities, and then making sure those people locate in the rural areas where we need them. We're fortunate in a way that we don't have the issues that the private sector has with mental health, where the CEO of Massachusetts General told me every mental health patient that walks in the door, he loses $100. We don't have that. So we can get mental health professionals working for us. We need to have the residencies and then need to work with the medical schools to create the throughput. And then I think what we're going to need to do, we do have some flexibility on reimbursement of medical school debt, and we do have flexibility on incenting people locating in rural areas, but I think if we could make that even more, that would be helpful, and we'll come back to you with the specifics on that.
I would appreciate a specific request, a level to which you need flexibility to bring these much-needed providers in underserved communities.
I also just want to thank you for your efforts. Through your efforts, we've worked with Texas Tech to be able to recruit additional psychiatrists into working in the VA. Very important to work with the community. We can't, as you know, we have 116 openings in El Paso. We've only been able to fill 91, 21% vacancy rate. So we need to work with private partners. I also want to thank you for your offer to go out and help us recruit. And I'm going to take you up on that offer. We're going to go out and we're going to recruit together. But we need everybody's help to let people know that if you're a mental health professional, the VA needs you. We want you. There are jobs available. Please come and work with us.
Thank you. Appreciate that. Thank you, Mr. Chairman.
Dr. Benishek, you're recognized.
Thank you, Mr. Chairman. Well, good to see you all again. I got a couple things I want to touch on. One is a sort of a specific item that came up to me yesterday, frankly. I had the the third-party administrator, HealthNet, the representatives come in to talk to me yesterday, and I asked them, you know, what are some of the problems with implementing access in the community? And one of the surprising things that the representative told me that in a lot of the cases, they have a hard time discerning what the VA wants for a provider. And that is because apparently the person who's actually making the consultation writes a brief note, like I need a thoracic surgeon for a thoracic aortic aneurysm. But by the time the third-party administrator gets it, it's a 30-page thing that they have to get a professional in there to kind of read through the 30 pages. Apparently, once the physician makes the request, some other bureaucrat gets hold of that request, adds a lot of the record to it, and they tell me that's a major delay in getting people to the right person. So I don't know how much you're familiar with that, maybe Dr. Shulkin is, but can you just please address that to me and see what you can do to fix that problem?
Yes. I think the process is very complex, and so we were meeting with the same person you probably were from HealthNet the other night in the Secretary's office, and what we agree is that we need to be together doing this. And in fact, we've started pilots throughout the country where we embed the staff from the TPA with the VA people, so it's not phone calls and faxes, but doing this together. So you're correct.
I just want to, that's one of the concerns I have with the third-party administrators. And all of a sudden, we got two bureaucracies now. We have the VA bureaucracy, and we have the third-party administrator bureaucracy, and this is a communication issue between the two of them. I don't know what the solution is. If better to have an outside bureaucracy, a private sector bureaucracy, or the VA bureaucracy, but
No, I think the solution is treat them as one and then use Lean Six Sigma to go through and lean the process so it becomes very linear, and that's what we're going to do.
That sounds pretty technical, and I don't
It's what business
understand
people do every day.
what it means. Let me just go into one more thing that I want to change the pitch a little bit. The chairman mentioned in his opening comments about Mr. Gibson's frustration with a process that occurred apparently in Albany for a medical director that was attempted to be disciplined in some manner and then got thwarted by the courts. Can you kind of tell us more about that? Because I want to be sure that you have the tools necessary to do the appropriate discipline. This is what we're talking about all the time. So what went wrong there? What's the story? Is there something we need to do? Can you kind of go into that a little bit more? I'm just not familiar enough.
The chairman was talking about three particular instances where Deputy Secretary Gibson, as the deciding authority, decided certain punishment as it pertains to three senior executive service employees. Those three appealed to the Merit System Protection Board, and in each of the three cases, the Merit System Protection Board, well, it's hard to generalize for the three, but basically in two of the cases, they said, it looks like what he said was right, that they lacked judgment in what they did, but they vacated the punishment because we didn't punish more people than just them. And what Deputy Secretary Gibson said, and we agree, is that it seemed to us like the Merit System Protection Board judges didn't understand the intent of Congress or our intent in punishing those employees. As a result of that, we had a discussion last night with the chairman and the ranking member about an idea we had. It was actually Deputy Secretary Gibson's idea that we make all VA employees Title 38 so that, because we are like a business, we happen to be if we were a company, we'd be a Fortune 6 company. Treat everybody in VA as a Title 38 employee, which would give us more flexibility in terms of paying them competitively in the medical community, as well as giving us greater flexibility in disciplining them without all of the things that happen with the senior executive service. So we have put that proposal forward. We have to do a lot more work on it. It's just preliminary. But we're going to work with the chairman and the ranking member to do that.
Thank you, Mr. Secretary.
And if I could, Mr. Secretary, a point of clarification. It's not all VA employees under Title 38, but the SES level, because
I'm sorry, yes, sir, you're right.
You just lit a fire. That
No, I didn't. Mr. Chairman, thank you for covering my back.
Anything I can do for you, Mr. Secretary. Ms. Custer, you're recognized, and I apologize for missing you before.
That's all right. Thank you very much, Mr. Chair, and thank you to the team here today for presenting the budget in such a coherent way. We appreciate it. I just wanted to follow up on Mr. Takano's line of questions and just to give a shout out to Mr. Kaufman and the Oversight and Investigations Subcommittee. We're going to be doing a regional hearing in New Hampshire on the 4th of March with the folks from White River Junction VA about the alternative remedies that they're using for to bring down the opiate prescriptions. And I think we'll be introducing legislation on best practices and moving that across the VA. And my hope would be that the VA, frankly, can be a leader nationally in bringing a bend in the curve on this opiate crisis. One of the things that we've learned in New Hampshire is that 4 out of 5 of our heroin addicts, where we've been particularly hard hit, 400 deaths last year, started on prescription medications, so we're really focused on that generally. But also 4 out of 5 have co-occurring mental health disorders. And so my questions, along with Congressman O'Rourke, are how we can bring more treatment, mental health treatment in the VA to the rural areas. And maybe we could consider legislation, not just for physicians, but for therapists, to encourage them to come to rural areas by alleviating their school debt. So that's one issue. The other issue, just focusing in on these evidence-based alternative therapies, I know that one of the problems we have, and this goes to actually from the Affordable Care Act, using pain as a fifth vital sign and as an indicator of quality. Again, our bipartisan task force is working across the aisle. I'm working with Representative Mooney from West Virginia on this. Is there anything in the VA where you're still using pain management as an indicator of quality that might be encouraging prescribers to use too much opiates? And can we help to turn that around? And would spreading these best practices help? And I'll end there.
Let me deal with the rural area medical infrastructure first. We had an interagency task force meeting on rural poverty, and the president was there. Sylvia Burwell, who's Secretary of HHS, Tom Vilsack, Secretary of Agriculture, and we had a long discussion about this medical infrastructure. I really do think there's a big opportunity to improve the medical infrastructure in rural areas. I know as a former CEO, when I would decide to put a plant somewhere, you look for infrastructure, you look for roads, you look for electricity, you look for water, you also look for medical care. And so we had a discussion about this, and many of the ideas that we've talked about, I think, are actionable for us, because VA trains 70% of the doctors in the country, so we need the residency slots. Then we need to work with the schools to create the residency training, because obviously it's difficult to create that kind of training program and frequency in a rural area given its location. So this is a ripe area for us to work together, I think, to really help our country. Ask David on the opioids.
Yeah, Congresswoman, I appreciate you bringing this attention again on this issue of opioid misuse and what we can do. VA has already begun to address this, but it has a lot more to do. As I said, we have 16,000 fewer veterans today taking opioids. We are using routine urine tox screens to identify people who are taking multiple drugs, because you're correct about the comorbidities of mental illness. We have started what's called academic detailing, which means that rather than going and talking to doctors about how to use drugs like the pharmaceutical industry, we actually are trying to teach them about the appropriate use of drugs and how they can avoid and use alternatives to opioids. So we do see VA as a national leader in this. We do think we need to do more. We are focused on this. We're looking forward to that hearing and seeing what else we can do.
Well, and just quickly, I'm the co-chair of a bipartisan task force on ending the heroin epidemic, and we would love to work with you, maybe some kind of a national panel, symposium, on how we can use the lessons from the VA to help civilian side prescribing habits. So thank you very much. I yield back.
Mr. Huelskamp, you're recognized.
Thank you, Mr. Chairman. I appreciate the topic of consideration today. Mr. Secretary, I appreciate the visit to my office yesterday, and I particularly was pleased by your continued commitment to work to make Veterans Choice permanent, and I think that is a critical item that we do need to pass. And we discussed a number of things, and I would like to first ask Dr. Shulkin to follow up on one thing we talked about, that, you know, I have 70 community hospitals and about 1,000 other providers now in the network. For choice, you have an announcement, I guess, of a way we can reduce the paperwork and simplify some of that process for our providers.
In terms of getting them paid?
Yes, and some of the
yes.
paperwork mandates that you had when you first implemented choice.
Right, yes. I'm having spent my life trying to get paid from managed care companies, I'm very sensitive to this. I believe that if you treat our veterans, you deserve to get paid and paid timely. So the major thing that we can do, and we will do this in the next 2 to 3 weeks, is we will decouple the requirement to submit all the medical records in order to get paid. So in other words, if you have an authorized claim or an authorized claim that's been submitted to us, we'll pay you and not require that you have to give us all of the medical records first. That will bring our payment rates up by almost 20% above where they are now.
And that will be implemented when?
We are waiting for final contracting approval within VA, we hope within 2 weeks.
All right.
That is a best practice in the private sector.
Absolutely, and I appreciate that. Again, I have a lot of providers, 70 community hospitals, and they want to help, and they also would like to get paid, and they also would like to cut through the paperwork. So I appreciate that. Other question is, I'd like to mention that I know Mr. Pummill had mentioned, I think it was at a hearing late last year, he said it was almost impossible to discipline most VA employees. And Mr. Secretary, do you agree with that statement, and if not, why?
I wasn't at the hearing, so I think the solution that we've talked about for SCS employees is for me, the answer to the question. We have terminated about 2,600 employees. That does include the expiring of probationary periods. We have 20 employees from 10 locations that have been disciplined for scheduling errors. So I guess I wouldn't agree with your statement, Danny. I don't know the context of it, but I would like to move forward on exploring what we need to do to get our discipline for SCS employees affected.
So, Mr. Pummill, could you explain, expand on that? And do you think the proposed legislative change would fix the issue? Apparently, we do have, I believe we do have a problem.
I still stand by my statement that I made last time. I made it in the context that it's too hard. It takes a lot of time, a lot of effort, a lot of money, time, effort, and money that we should be used taking care of veterans to follow rigid rules and procedures and policies. I do think what the Secretary's proposed with the Title 38 with the SCS would go a long way, not just to helping us hire better people, but with the long-term disciplining of people out there. But that's a good start. But I also agree with the Secretary that we got to concentrate on this budget and move forward and get going on stuff.
Absolutely, and Secretary and I talked about the VA Accountability Act, and there's some provisions in there definitely would help that if the Senate would move forward, and the administration could be supportive of that. And one of the things we talked about in the last month in the committee and was when I discovered, maybe the rest of the committee knew about the individuals in Phoenix that were on 600 days of paid leave. I thought we were going to fix that situation. Their paid leave is over, but they're now working for the VA again. And if we can't fix that situation, can you explain, Mr. Secretary, of how folks that I think we all agreed would not be working for the VA, 600 paid days, and at the end of the day are still working at the VA and other
Yes, sir. Well, you recall in the testimony Sloan Gibson gave, Deputy Secretary, he said that we were going to change our policy, that the policy of waiting for the IG investigation to be over was taking us much too long. So we're now doing our own investigations and bringing charges much more quickly. In the case of those individuals in Phoenix, we expect within the next couple of weeks you'll be hearing something about that. We're wrapping that up.
And that those were the folks that were on paid leave, or the other two folks that these are the ones that targeted the whistleblowers?
There were two people in question who were on administrative leave. We have brought them back to work. In fact, immediately after that hearing, we brought them back to work, and they're now working in the VISN headquarters. And there's a third individual that was part of the investigation who is currently working within the facility.
All right. Thank you, Mr. Chairman. I yield back.
Mr. Waltz, you're recognized.
Thank you, Chairman. Mr. Secretary, thank you to you and your team for the work you do. And we're just, I know it's early here and we're still parsing through the budget, but we all know budgets are more than just finances. It's a moral document that reflects our values. And so when you bring these issues to us, we're trying to find, and each of us is pulling out things that, that are important to our veterans. And I know that I don't want to oversimplify, but that's probably exactly what I'll do. But this issue keeps coming back on opiate addiction and some of those, and it ties in closely to the issues Mr. O'Rourke and Ms. Custer talked about, that they're all interconnected on the mental health piece, on suicides and things. I think you heard, and I point this out, one of the root causes of opiate and opiate addiction is pain as the systemic cause. And I bring this up because you're hearing this, and I'm going to reflect a little frustration that we're always seen somewhat as being reactive here. We were proactive. 8 years ago, the best minds out in the private sector dealing with pain management put together and passed, we did it here, the VA Pain Management Care Act. And it was meant to be the best practices, step-tiered, and it was all aimed at treating the pain and reducing, because I think just showing opiate numbers, sometimes people need them. And I think just showing a reduction, I've got people calling my office who there's nothing in between. They're off and on. So it's more complex than that. And we put this thing into place, and a year ago, or I guess it wasn't quite a year, in June last year, Dr. Clancy testified, it was never fully implemented. And it expired and was not reauthorized. And I asked at that time to get a full accounting of that, because it was already 3 months before that I'd asked. I've never received an answer. This was a bill that Congress passed, proactively addressing what smart people outside of there and in here crafted together to prevent this very thing we're seeing now. And so I know you're doing it, and I know that was a different world. That was not you. That was not your administration. I point it out, though, because I think at the risk of the frustration of the American people, we want to fully fund what you need to do this. And this Congress passed and funded the Vet Pain Management Act that people out there still believe is the best way to reduce opium addiction, never implemented, no answer why, expired, business as usual.
We'll get you that accounting back, that reconciliation back. It's my sense, Congressman Walz, that many of the things that were in that bill we are implementing.
I think you are too.
But
I believe that.
We owe you an accounting back as to what we are doing, what we're not doing, and why. But my sense is we're doing a lot of that.
I think that
those were
feedback,
all good best practices.
Yeah, I think so. And my guess is you're exactly right. I think it's probably happening. But there's a disconnect between that, the private sector pain management experts, and this goes into device manufacturers that are coming up with things to block this. I mean, you know more about this, Dr. Shulkin, than I do. These folks come to me, and the disconnect back here to Congress, and then I think some of us who've been here, we're going to see well-meaning members who come here, and they're going to tackle an issue that we've already tackled once, or we've done it again. And then that's that reinventing the wheel that in a budget, I don't want to see any of those resources not go to exactly what you need them for. So I certainly don't want to say that they weren't being enacted.
The only thing I would add to that is in the different conferences I've spoke at, in the different medical schools where I've spoken, there's a clear need of the faculty to do a better job teaching pain management. Yeah. There just hasn't been enough training in medical school on pain management.
And private sector.
So we're trying to go upstream and get some of these things dealt with strategically rather than just the what happens.
We treat addiction after it's there, good luck.
Right.
We all know what that goes. We know recidivism rates. We know everything else and all of the heartache and the destruction of lives that go with it. That's why this was implemented, to track these people through from the very beginning with a case manager on pain and that. And so if you take a look at that, I'd appreciate it. I think we come back, and I know you're doing this. I know there's experts in this, but I'm hearing it from the outside that we really missed an opportunity to get on the front end. And maybe I'll segue into that. Implementation of Clay Hunt Act. I know you talked about it at the conference. I know it's real. I think Mr. O'Rourke is pointing out what's right. I know in this case that the commitment from the VA is there to get this on the forefront. I do think it's important to keep mentioning that it is a priority. It is out there. We are implementing, and we're going to see what happens with that. I'll leave with my last comment on this, and this is just, I guess, the Agent Orange Act expired. I'm not convinced all the research is in yet, but it is what it is. You still have the ability on presumptions. Where does that fall into this? Because we know what happens when something's added on this. It all ties together with case backlogs, NEMR, and everything else. So.
One of the things I've tried to do as secretary in my 20-some months so far is to look at a lot of these things that have lingered for some period of time. The chairman was kind to mention the 5-year-old lawsuit we had in Los Angeles that was paralyzing our ability to do things on our campus there, our 388-acre campus there. So I've taken a look at a number of these things. C-123 Agent Orange, reservists literally scraping out the residue of Agent Orange from these airplanes. And I've put in place a more liberal interpretation which gets those veterans the presumptive cares that they need. I've done the same thing with the presumptions around Camp Lejeune, where we've included 8 presumptions for Marines at Camp Lejeune. I just took a look at Blue Water Navy. I went back through the Institute of Medicine study. I also went through the Australian study, and it was my point of view that the science doesn't exist yet to do a presumptive for Blue Water Navy.
My time's going to be up, Mr. Secretary, and I want to thank you for all those. I guess maybe, do you need the act to further the science? See, that's my fear.
No, I don't think so. In
Okay.
fact, what we did with the Blue Water Navy is we didn't want to just say no. So what we've done is we've formed groups now to go out and do the research to discover whether or not we should create presumptions for Blue Water Navy.
And I am grateful for that. I yield back. Thank you, Mr. Chairman.
Thank you very much. Mr. Waltz ate up 1 minute of your time, Mr. Kaufman, so you're recognized.
Thank you, Mr. Chairman.
5 minutes.
And Mr. Secretary, thank you so much for stopping by my office yesterday evening to brief me personally on the budget. Congressman Lamborn asked about the IG report in Colorado Springs and asked the status of the manager that was removed. And there wasn't an answer given to that, so let me follow up with that. What is the status of the manager that was removed?
Congressman, my understanding is, as the Secretary had said earlier, that we have replaced the supervisor who was responsible for the scheduling. That person went to work in another part of the facility.
What disciplinary action did they receive?
I am not aware that there was a specific disciplinary action for that individual.
Mr. Secretary, don't you think that's a problem?
Not the way I read the IG report, Congressman. I think if you look at the IG report does not call out anyone for malfeasance. What it does indicate is, number one, we didn't train the people properly.
Who was responsible for that?
Well, the leader is always responsible.
Well, then why weren't they held accountable?
Well, they are held accountable. They're held
What?
accountable in their performance review. That doesn't necessarily mean they get fired.
Or disciplined.
Firing doesn't lead to
Or
excellence
disciplined.
in an organization.
Or disciplined?
Well, discipline occurs on many different levels. I mean,
Well, I'd like to know specifically what discipline he
well, we'll
was.
get back to you. We'll get back to you on how it was handled.
Well, thank you. When you mentioned Title 38 on SES, what percentage of the workforce would that apply to?
Well, SES is about 540 or so individuals of a total of about 360,000.
Mm-hmm. So what about what?
They are the senior leaders of the organization.
And what reforms are you putting forward? Your best professional judgment, given the fact that you came from the private sector, what personnel reforms are you putting in for the others, for the rank and file?
Yeah, right now, as I told you, we're training the organization in mission and values and leadership. We've taken over 12,000 people and trained them. We've had these training sessions are cascading throughout the organization.
So there are no reforms in terms of making it easier to let poor performers go. You're not putting any reforms in that direction.
We have let 2,600 people go.
Okay. Why? We had, I think it was House Resolution 280 that came before the Congress, and we had testimony from your staff that you were neutral on that. Let me explain what that does. One of the biggest scandals the VA has had is on the appointment wait times, and I think that corruption was fed through bonus money. It was fueled through bonus money to bring those down. And yet we've had legislation before us that your office is neutral on that says that you ought to have the ability to claw back bonuses when they're fraudulently given. The only way that you can currently claw back bonuses under existing law is if it's administratively given to the wrong person and for no other reason. Why would you be neutral on such a simple reform like that?
Well, bonus spending across the VA is down and down dramatically. In 2015,
That's not the
total
question.
VA spending for all award categories.
Sure, but why
was a
would you,
reduction of
somebody who
$19 million,
fraudulently received a bonus,
7%
why
below
would
the
you
previous
demand
year.
that the
And
taxpayers and the
There's
veterans
a graph that shows you
get
the
that back?
reduction in bonus spending. And as I've laid out for the chairman a couple of times.
So you're okay,
we are-
let me get this straight. You're okay with somebody who's got a bonus, even though it's been proven that they should have never got that bonus because their conduct that was fraudulent in receiving that bonus, like under the appointment wait times. So what you're saying by not supporting that legislation is you're okay with that?
I'm working on the future, not the past.
Well,
And, the future is about making sure people are given performance awards that measure what they do. And that's why we're bringing the bonus totals down for the department. And that's why we're relatively rating people consistent with the best practices in the private sector.
We had Glenn Hagstrom, who $1 billion over budget in the Aurora VA hospital, retired just right before he was supposed to be interviewed by the AIB. We just had Dr. Shinazi retired just before, just after the story broke about the Hep C problem, where he was a researcher with VA, helped develop the drug there. And then left, and then took that intellectual property, created a private entity where VA did business with that private entity. And he retired. I mean, you know, what is going on? Here's the problem, that you're saying great things here, but you're not attacking the heart of the problems. And the heart of the problem is we have a horrible personnel system that that allows this bureaucratic incompetence, that allows this corruption to continue. Where are you on this?
Congressman Kaufman, as I said earlier, I think if we can work on reclassifying the SCSs as Title 38, that would be a big step forward. And, you know, as we've said previously, you can't fire your way to excellence. And it's my experience that we're
might be a good start.
The right steps. We are taking the right steps.
It might be a good start
to create a high-performance organization.
I think firing incompetent people would be a good start.
And by the way, I don't think I have the authority to claw back somebody's bonus after they retire. If you want that, you'll have to change the law. I don't write the laws.
Support the law, and we have legislation.
I don't write the laws.
Thank you very much. And also to bring all the members up to speed, we are working with the Four Corners on trying to pre-conference and negotiate a lot of these issues. Both sides are working collectively. The language that you referred to has passed the House. We are trying to get our Senate colleagues to follow us so that we can, in fact, change the law so that for those who have broken the law in particular and have been convicted, to give you the ability or your successor to go in and claw that bonus back. I think that's an important tool that we should focus on. You don't have that ability now. We found that out after Pittsburgh, I think, was the Legionnaires issue there. Mr. McNerney?
I thank the chairman, and I thank you, Mr. Secretary, and your staff for your hard work on developing this budget. I have some parochial questions, if you don't mind. The Palo Alto VA is in my, it's not in my district, but a lot of my veterans use that, and they provide excellent service, no doubt about it. But it's in a very high price area. It's very expensive to live in Palo Alto, and commute there is murder. Do you have any way to compensate for high cost areas for your employees? Because they're going to be cost, you know, they're going to be priced out of that office.
We do have some flexibility, sir, for location premiums. I would argue it's not enough. And if we can do what we talked about with Title 38, that would give us more flexibility. The Palo Alto facility is one of our very best. Many of the doctors there also teach at Stanford Medical School, and we do a lot of research there. It's really an outstanding facility. It's probably one of our best Lean Six Sigma facilities in the country.
I agree. Moving on, the VA has a construction backlog that can last years. Of course, we've experienced that in my district on the French Camp facility. Are you in support of public-private partnerships or partnerships with local governments where the state, for example, can pay part of the construction fees and partner with the VA or the Corps of Engineers?
We have done that. in the past, and that's one of the reasons we're looking for the extended use leasing on the Los Angeles campus.
Do you find that to be, have you found that to be a successful model?
Yes, in fact, at Menlo Park, which is very close to the Palo Alto campus, we have an extended use lease going with a company called Core, who built a building for aging veterans, and we are leasing that building back from them, or renting that building back from them.
The last question has to do with the way veterans use VA benefits. Do you track demographic data like gender or ethnic group or economic class in terms of how the benefits are distributed?
We have pretty extensive data, location, whether or not they're married, the age of the veteran. I'm not sure if we track economic, but everything else we pretty much have.
Could that be made available to my office, that information?
Sure, we actually put out a book every year by state with all that data. We can make sure you get a copy.
Okay, I mean, the plan that you put forth is ambitious. It's good. The VA needs to modernize, and I think everyone on the committee here is behind this effort. There's going to be some disagreements, but my hats are off to your efforts, and we're going to try and support you the best we can. Mr. Chairman.
Ms. Walorski, you're recognized.
Thank you, Mr. Chairman, and thank you, Mr. Secretary, for being here today and bringing your team. And I just wanted to say how thrilled I am to hear that you've made the transition to the concept of running on principle and not just necessarily on the bureaucratic rules in the VA, because there's so many. I look forward to that as it kind of winds out my district. Ms. Counsel, not to leave you out, I've been interested in this issue with IT since I've been here in Congress, and I'm just curious. You're asking for, the VA is requesting $4.2 billion for cutting-edge information technology. I've heard that probably 3 times since I've been here, of the additional billions of dollars that have to go into this new cutting-edge technology. My first question is just quickly, how much of that money is going to be kept for just maintaining the legacy systems we have, and then how much of that is actually being carved out for new cutting-edge technology?
I don't have the breakdown, but I will get that to you. What I will tell you is we have a large legacy issue that we need to address. We are increasing our spend on security to $370 million, fully funding and fully resourcing our security capability. In addition, we're putting in well over $50 million in creating a data management backbone that we didn't have, and we've added 5 new functions within the organization that will modernize the IT organization.
Let me ask you this just quickly. So is this money you're requesting, this $4.28 billion, is this going to take care then of the maintenance of the legacy system and achieve the goals that you're talking about right now? Or are we going to be looking next year at another $5 billion, another $6 billion? Is this take care and suffice to get the VA where you need to be per the goals that you just talked about?
Yes, it does.
Okay, I appreciate that. And Secretary McDonald, I just wanted to again bring you up to speed with what's happening in the state of Indiana. And I'm again asking that you come and visit our Northern Indiana vision. You know, 2 of the things that continue to be an issue, and for as fast as you're working to reform these things and for the footsteps that we're taking forward on reform, and we are, and I appreciate that. You know, we still deal with an issue in our district. It's probably not unlike anybody else in the country, but it really makes a difference in our district, is that all of our top-level VISN executives have been promoted around the country. And now we're just not dealing with doctor shortages and nursing shortages. Now we're dealing with administrative shortages. So when a veteran exhausts all you know, appeals and those processes, they come to the congressional office and they say, will you help? And they're at the end of their end. And now, as we have to get involved in that with congressional inquiries and battling for the sake of our veterans and trying to bring those mountains down, we're going through temporary people that really aren't really accountable to anybody, and it's really provides zero transparency then as we try to come and in good faith with the VA, try to figure out where some of these mishaps are. And I just want to give you the one example because I'm going to need your help on this situation is I've got a veteran that was in the appeals process for years, And it's been back and forth where the VA will say, no, they'll deny them, and then they'll come back and they'll prove some point, and they'll say yes, they'll say no, and they'll say yes. This guy in bad health with serious heart complications and surgeries is left holding a bag that now the VA says, yes, we're going to pay the bill, and the hospitals are coming back to him with interest over the last 4 years. I've got a veteran right now responsible for $10,000 of interest, and this was never his fault. But I look at part of that of saying, can you help us mitigate that with the VA, number one. Number two, how long can we possibly, and can the VA possibly run with temporary administrators?
If you could, Congresswoman, please get me his name.
I will.
And I will work on that. We have the ability to give relief on that. If we made a mistake, to give relief, financial relief on that interest that he would be charged. So on all these things, don't you know, if a veteran comes to you, give him my phone number, give him my email address. You don't need to deal with it. We will, and we'll get it effectively resolved. The issue you mentioned on vacancies is one of the biggest issues we face, if not the biggest issue we face. It's ironic that when I talk to our organization, and I do that a lot, because whenever I go anywhere, I do a town hall meeting, they tell me that people don't want to join VA because it's a maligned organization and everybody's being fired. And then I come and sit in front of you and you tell me nobody's being fired. And the truth, of course, is somewhere in the middle. And our applications are down over 75% for available positions, and that's just unacceptable. It's a great place to work, and I've encouraged each and every one of you, and the chairman has done it, and the ranking member, to go recruiting with me. And let's stand together and recruit the future leaders of this organization.
Just curious, does this budget reflect any kind of new recruitment efforts or the tools that you need to do that?
Absolutely.
Okay, I appreciate that. I yield back, Mr. Chairman. Thank you.
Dr. Abraham, you're recognized.
Thank you, Mr. Chairman, and thank the members for being here. Mr. Walsh brought up something I think that is so important, and that's the moral duty and the ethical duty that we as a committee and you as the VA have to our veterans to ensure that the money that we give you is spent in the best fashion so that as many veterans as possible can get the best care. And I know you agree with that statement. Certainly, it goes also to the trust issue. As a physician, I write a prescription, I give a diagnosis, that patient, trust me, if I make the wrong decision, that patient could very easily die. And in your arena too, the decisions that y'all make certainly deal with life and death on almost a daily basis, such as in any physician. And it brings me to the question I'm going to ask you, Mr. Secretary. Let's go back to this IG report that we keep going back and forth here. Last month, the IG testified that due to data manipulation, that the VA's backlog statistics were not reliable. And my question is, how can we trust the department's current figures when it comes to the request to fund 300 additional non-rating claims processors, 900 additional Board of Appeal staff? So where is that trust that we as a committee and the veterans, how can you ensure that?
You know, our data and our data integrity is absolutely critical to our success, as it is to any business. So obviously it's something we're working very hard on. I did not read that IG report as conclusively as you did, that because it sounded from what you said as if all of our data was not good.
I'm just ponying on what the IG
could you
said.
comment a little bit on this? Because
Congressman, I have read the report. I absolutely disagree with the IG statement that the
let me
backlog.
interrupt. I mean, he is an expert in his field.
I don't believe he is, or he wouldn't have said that.
Well,
if you
then
look at the
there's a
statistics.
big divide there. Then I would argue that if we've got an inspector general of the VA's department saying one thing, you guys saying something else, where is the trust that veteran? Where is he going to find who to trust?
The bottom line, Congressman, is last year we paid out more money to more veterans faster than we ever have in the history of the VA. All those stats are there. All that data is there. 1.4 million veterans, over $90 billion in benefits and services. I mean, huge numbers out there. And we're doing more and more and more, and we're doing it faster and faster to veterans. So I disagree with.
You're reading the same report. I'm sure I am. the transcript of the IG's report last
Believe me,
night.
sir, we
Yes,
read the
I am.
reports.
I
We read the
absolutely-
reports.
You know, I just have, I'm just having
As you
a hard
know, we
time
don't have an
getting it.
IG right now.
I understand that,
And
but-
we have nominated, the president's nominated a very talented individual that we're trying to get confirmed by the Senate. And I think what you'll see is the quality of our work will go up.
I mean, you know, as a guy that deals in the objective, I just have a hard time understanding how there can just be spaces of worlds apart between your opinion and the IG's when you have data that is just in black and white. And we will continue to debate.
But
I want to get another question. Let me get another question, Mr. Secretary. The department's budget proposal put forth is about the simplified appeals process that would consist of closing records on appeals and eliminating what are termed optional hearings. And I guess what I'm asking, please provide details about the proposal, including how it will strike, and it is a delicate balance, I realize, of achieving timely, accurate, and fair appeals decisions for veterans and their families.
As we said, Congressman, the proposal we put forward is a straw man. If you have better ideas, we'd love to hear them.
We will get
And as veteran service organizations have better ideas, we'd love to hear them.
Okay.
What we all know is today is untenable. It's unacceptable.
and I will
And
certainly
what
agree
we're
with that.
committing to with this proposal is, as we said, in the future, 90% of appeals done in 1 year. So let's work together, let's get this done, and we're open to any idea, just like Congressman O'Rourke gave us an idea last week, and we changed.
And just a real quick, of that 440,000 that are in the cycle now, is there just a guesstimate or an educated guesstimate? How many are those within the 2 or 3 year process appeal?
I have to get back to you,
That's
sir.
fine.
I don't
Fair
know.
enough.
I don't know the answer to that.
Fair enough. Thank you, Mr. Chairman.
Given that 2% of the people create roughly half of the appeals, I would assume that there's quite a few that this is their, multiple appeal.
So maybe past the 3 year?
Yeah.
Okay, thank you. Thank you, Mr. Chairman.
Thank you very much, Mr. Takano. Do you have a closing question, please?
Mr. Secretary, I really want to get an answer on your planning for more graduate school medical education. That was more GMEs. And is your resourcing that you're asking for, is it adequate for what we need in the future? We did insert 1,500 more GMEs in the Choice Act, but the medical associations are all telling us they need more. And I'm of the mind that this is perhaps the best area, the best committee to be able to try to make some headway into the overall doctor supply. And what you're doing to consolidate care in the community, I think, might enable us to have this be a platform.
Congressman, first of all, thank you to the Congress for giving us the 1,500 slots. The country needs them. We need more graduate medical education slots, and VA can really help in this. But of the 1,500 slots, we've only used 372 today. And what we've learned is that we actually can't do everything that VA needs to do because we need the hospitals. We work with affiliate hospitals. They don't have the infrastructure and they don't have the ability to pay for these. So we would like to work with you and members of the Doctors Caucus or anybody else who would like to give us the flexibility to help actually expand these graduate medical education programs further. We'd like to focus in primary care and mental health and in rural areas, absolutely. But we do need some additional flexibility to actually carry out the intent of Congress here.
Well, I hope that, I appreciate you working with Dr. Rowe and the Doctors Caucus, but there are other of us who, Ms. Titus, myself, and Mr. O'Rourke actually were co-authors of that language that got into the Choice Act. We'd be happy to work with you on that. The primary care doctors in mental health are exactly what a lot of regions need, rural regions and suburban, urbanized regions such as mine. We're under-doctored, and so we definitely want to work with you on those issues.
Okay, thank you.
Thank you.
Real quickly, Mr. Secretary, we talked about where the budget expands and spends more money, invests more in veteran programs. Could you give us 2 or 3 examples of where this budget goes in and actually cuts some wasteful spending in programs, not efficiencies, I'm talking about eliminates from the program?
Construction and Vista.
Go ahead.
Two areas where we have significant decreases, as you know, are in construction. We've actually taken our budget down significantly until we get the commission on care findings.
That doesn't count.
No? Okay. How about
Try
this one
again.
then? We've actually reduced our funding for our EMR this year until we, Ms. Council, and I and the Secretary and others get a clear plan on where we want to go with our electronic medical record.
My question was wasteful spending, and I don't think you'd say the electronic medical record is wasteful spending. We're talking about a now $80 billion budget. Is there anything that was eliminated this year?
Well, we'd like to close those 10 million square feet of unused space. We have more space being created because we're saving about 5,000 tons of paper a year in VBA. The other thing I will tell you is we're only at the beginning of this. As part of our training program, this Leaders Developing Leaders, we have put in place a process called RAMP, which stands for reports, meetings, priorities, so forth, where groups of people get together and actually stop work that they're doing. We haven't put dollar amounts against all of that yet. We are cataloging all the things we're stopping doing, and then we'll put dollar amounts against it, and we'll come back to you and tell you what those dollar amounts are. Remember, in this budget, too, one of the things we're proposing, if you'll help us, is the creation of a unified, holistic supply chain for VHA. There's a lot of money sitting on the table. We're committing here to saving at least $150 million if you can help us do that. Right now, each one of our facilities has its own supply chain. We know by consolidating those supply chains, we can save a lot of money.
And I appreciate that, and I do think you need to be looking for efficiencies, and I know that's something that you're focused on, but
it's in our written testimony.
But surely somewhere in a $170 billion budget, there is waste that could be eliminated, and if you would, have some folks go out and search around. We need to go ahead and adjourn now, but if you would, for the record, we'll take that. And obviously, we're all trying to absorb as much of the budget as we can. So as we look through it, there will be more questions that this committee will have. And I would, as our custom, say that all members would have 5 legislative days with which to revise and extend or add extraneous material to their remarks. Without objection, so ordered. And with that, this hearing is adjourned.